Welcome to the Hassenfeld Child Health Innovation Institute Spotlight on Autism. On behalf of myself and our speakers today, Dr. Daniel Moreno De Luca and Dr. Stephen Sheinkopf, as well as the rest of the leadership for the Hassenfeld Institute, Dr. Phyllis Dennery and Dr. Maureen Phipps, I want to welcome you to our talk today. And before we get started, I want to say we have no disclosures to let you know about. But also want to introduce you to the newly launched Hassenfeld Child Health Innovation Institute, being launched here by President Paxson. The Institute was made possible by a gift from the family of Alan Hassenfeld and really brings together the leadership at Brown and Rhode Island more generally to focus on maternal and child health issues. At Brown, this includes particularly the Alpert Medical School and the School of Public Health, as well as departments throughout the university and our affiliated hospitals, Hasbro Children's Hospital, the only pediatric children's hospital in the state, Bradley Hospital, a children's psychiatric hospital, and Women and Infants Hospital, the place of birth for 3/4 of Rhode Island's children, as well as our community partners like state government, the Rhode Island Department of Health and Department of Education, and community organizations like Rhode Island Kids Count. And what the Institute does is to bring these organizations together to try to make this the healthiest place in the world for children. And one can't do that without addressing the critical issue of poverty, as well as the broad range of issues that affect child health. And we really want to do this through cutting-edge research and evaluation, some of which you'll hear about today in autism, to try to be national and international leaders as far as what's possible in maternal and child health. And in all of this, we integrate learners at Brown. We're big believers in learning by doing, both as the best way for students to learn, and also for them to make important contributions while they're here as students. And for those of you who are parents, as it's family weekend, we do have paid internship programs in the summer that you can tell your children about and refer them to us. I'm happy to stay around after the talk if you have broader questions about the Institute. We address a broad range of child health issues, but one of our signature features is the talk that you're going to hear about today on the issue of autism. So I'll turn it over to Dr. Sheinkopf and Dr. Moreno De Luca.
Good morning. So I'm going to start off by just a quick introduction about what we think of what autism is, and then move to just some research that we're conducting on autism in infancy. And this will give me a chance to highlight a couple of the initiatives here as well. We'll see if I can get this to work here. Okay, good. So what is autism? So autism is a developmental disability. It's characterized by symptoms, difficulties in the development of social communication, social play, an excess of repetitive interest or repetitive behaviors that appear early in development and that are impairing, that get in the way of development. We think of autism as a developmental disability, and a good way to think about this is that it affects development, of course. It changes the course of development for children, but it's affected by development as well. So the nature of autism, the way symptoms present, changes as people grow older into childhood, adolescence, and beyond. It's much more frequent than we once thought. If we were giving this talk in 1989, we might say it was 2 to 5 people per 10,000. But it's known to be much more common than that now. The most recent Centers for Disease Control estimate was somewhere in the vicinity of 1 per 68 people. There's probably some controversy about what exactly the number is, but it's much more common than once thought. There's a question here, I'm sorry.
Yeah, is that because the definition has expanded, or because we've become better at screening?
So the question is, why the increase in prevalence? Is it definitional changes or increased screening? I think both things might occur. I think one controversy, and a thing that I think the field needs to grapple with, is where do we draw our boundaries, our bar for determining who has an autism spectrum disorder, and that's going to change the prevalence a bit. So some studies show even higher prevalence estimates, but I think some of the questions about those studies are, to what degree do you need to demonstrate that somebody has clinical impairment, difficulty getting along in whatever parts of the world they need to get along in, to sort of define a diagnosis, versus are we talking about sort of a range of personality characteristics. So there's some things that I think are unsettled in the field that might shift sort of the actual prevalence numbers in the future. It's much more common in males than females. And it's associated with other comorbidities as well. So roughly 30% of individuals with ASD have seizures at some point in their lives. And intellectual disability, that's a term that's used now for what used to be called mental retardation, is present in roughly 30 to 40% of individuals with ASD. That's changed over the years, so again, if this talk was being given in the late 80s, it would be the majority of people with ASD would have been estimated to have intellectual disability. And that lower number now probably speaks to improved treatment, but also we're diagnosing different individuals than we used to. So both things are at play. What I want to talk about for this first part of this talk is some initiatives that we are engaged in to think about autism in infancy. Typically, autism is not diagnosed until children are around 2 to 4 years of age. 2 would be a very young diagnosis. 4 or 5 would be a bit of a later diagnosis. I think the average nationally is probably in the 4-year age range. So this is a it's a very difficult developmental disorder. There are highly characteristic features that are apparent by age 2 to 3, but we can't diagnose it early in life. And so the question is, can we find out through novel methods examining potential risk factors for later diagnosis of autism? And can we study how children who have a later diagnosis with autism develop during infancy? Might that tell us something fundamental about the disorder and how to and when to intervene? So I want to start by just showing you 2 videos. These are 2 babies who we followed over the years. One of them, and I won't tell you which one now, we know has grown up to have an autism spectrum disorder diagnosis. I'm going to set up the clips for you. It's a face-to-face interaction. Prior to these clips, the moms were interacting with the babies. These 4-month-olds are now going to be interacting with a stranger, a new adult, who's going to enter the room. This is a split screen. It's a split screen here, so they're actually facing each other. We just need the camera angle on each one. So watch these, and I think my question for you is, could you tell who might be at risk for autism from these videos?
Joshua, hello guys. Yeah, hello, what a nice smile. Was that a nice nap that you took? I think so. I got your teeth. Oh my goodness, you're cutting teeth. I can see them. Yes, I can. What a good boy you are. No, I'm not worried.
Little guy, and here's the next child.
What's wrong? Yeah. How are you? Yeah. I love your sneakers. I think your sneakers are neat. I do. I like your sneakers. Yeah, you got nice sneakers. And you got such a nice little outfit on. You trying to say something? Are you trying to talk?
So now comes the interactive part. A totally unfair question, right? But if you had to guess, if you had to make sort of some judgment about who might be at risk for a social communication deficit later in life, I guess would you point to the baby on the left or the right? If you think the baby on the left, maybe raise your hand. And the baby on the right? Okay. Of course, I'm totally unfair, and I was cruel because I gave you some sort of an impossible problem, but it's really the baby on the left who ended up having autism. And that's him below at age 5. And we've followed him. He's now 19 or 20 years old now, and he's a very significantly affected young man now. And you can start to see at age 5, he's nonverbal. He's not really communicative. He taps things repetitively. And it's a tragic outcome for this now young man. And when we look at these 2 videos, I show these to underscore the difficulty of the problem we're facing, which is how do we understand the trajectory of development from infancy to childhood. How does something how does a condition that's so profoundly apparent in many cases, not all cases, but in many cases, start off so subtly? And what can we learn from infants as we study them in this way? So one thing we know from research is that studies have really shown that this actually is really true, that the social deficits of autism are quite subtle early on and magnify with age. These are data from California showing that, let's see here, okay, showing that the degree to which children who have a later diagnosis with autism hear direct vocalizations to other people and look at other people is pretty similar to non-affected individuals in the first year of life, and then the curves really separate after 12 months of life or so. So this phenomenon that we see in this video is being borne out in research as well. One effort that we're engaged in here at Brown is to then think about, well, maybe there are more subtle ways we can measure social responses and social behaviors in infancy, but perhaps we need to cast a broader net developmentally in terms of what we might look at as potential indicators of risk for autism. So one area that we're currently engaged in looking at is the degree to which early vocal development is different in children with autism. We know it's very different in children diagnosed with autism, and the question is, can we detect that difference even in early infancy? And so one method of doing that is to examine vocalizations that are produced in highly arousing states, infant crying. And so we have a series of studies looking at the acoustics and the perception of crying in infants later diagnosed with autism. So we know that autism is characterized by atypical vocalizations. Can we see this early in infancy? This is what a cry looks like. This is a spectrograph of a cry. So you can think of a cry as a sort of a repeated set of exhaled vocalizations, wah, wah, wah. And we can see the acoustic structure of these cries here. And we can measure and quantify some of the features from these cries. We found that babies at risk for autism have a difference in the pitch of their cries. We call that fundamental frequency. We hear that as pitch. And babies later diagnosed with autism from this sample of at-risk babies had especially elevated pitch in their cries, and this was at 6 months of age. We have some additional samples of cries of babies when they were 1 month of age, followed out into childhood and adolescence. The cries on the left are sort of the pictorial representations of the cries of just 4 examples of typical children, and here are 4 infants with later diagnoses of autism. I'm going to show you how these cries are perceived differently by parents, but you can see that they look different as well, and we're looking to find ways to, in a quantifiable terms, sort of describe that difference. But we see that they're more messy. They have more tension in the vocal tract. They sound different, and the acoustics are such that that we think we can quantify the difference, but that's something that we're working on currently. Dr. Vivier mentioned that students are often involved in research here at Brown, and this is a good example. We had an honors thesis student from Department of Cognitive and Linguistic Psychological Sciences conduct an honors thesis using some of these data, and what she did was to enroll a group of parents, some with a child with autism and some with a child with typical development, to listen to those cries that gave you the pictorial examples of, and ask them some questions about these cries. And so these cries across a range of individuals were rated as sounding more distressed and less typical than cries produced by typically developing children. It's a question.
Are these in response to perhaps overstimulation, or because it's not clear from the charts, or are these just in social inter?
So these cries, so these cries that were studied were elicited in a standard way. So we can That's quite important for these studies. We need to standardize our measurements so that we don't have variability that's not associated with the things that we want to measure. So in these studies, babies were stimulated by a small, non-invasive, but it hurt, little slap to the bottom of their foot, and then we observed a cry there. And that little slap to the bottom of the foot was calibrated so it's the same strength for all babies. So that's important. So we think that there may be some difference in perhaps the arousal response to the standard stimulus. So this is an example of one way we might be able to investigate at least one aspect of arousal response in vocal production in infants with later diagnoses of autism. Another way that we're currently investigating this as well is to think about other physiologic measures of arousal and regulation. So I'm a clinical and developmental psychologist. In our world, we call this psychophysiology, meaning the study of physiologic responses to social events, to times where cognitive load or processing might be sort of challenging a child in different ways. So what we have here is a study that capitalized on a large, ongoing developmental study, longitudinal study of child development. It enrolled 1,400 babies, followed them longitudinally into adolescence. Brown University was the lead site for that study. And it was large enough that there happened to be 13 children with autism who were later identified in that study. So we clarified those diagnoses, and then we looked back at early infancy to see if we could detect any differences early on. And what we're measuring here is a physiologic phenomenon called respiratory sinus arrhythmia. It's something that's a mammalian phenomenon, and it has to do with the variability of heart rate in time with respiration. So as we're breathing in and out, there's information that's flowing from our brainstem to the sinoatrial node, the pacemaker of the heart, that results in a fluctuation of the beat-to-beat intervals. And so this is a heart rate measure that's mediated by the brain. And that's impacted by stress and arousal and attention. So we think that higher RSA, higher amounts of this variability, is related to an individual's ability to engage, regulate, respond adaptively to things around them. And what we see here is two curves, growth curves of RSA. So we know that this increases towards adult levels in typical development, and that's the solid line here. And those are typically developing children. And this is a group of 13 babies later diagnosed with autism who had first developed and grow normally, but sometime in the second year of life, the growth curve falls off. And so there seems to be some difference in development of regulation and readiness to engage with the environment in the second year of life. And we know clinically that that's a time when symptoms begin to really emerge. And so we can think about these. I have no great conclusions on this, but rather highlighting this as a potential model for how we can use growth trajectories to understand what happens when in the development of children with autism, with the idea that this might help us understand critical periods in development that children may be most open to intervention, and when we might be reasonably able to do some early screening and identification as well. We're not there yet in terms of that early screening and identification, but that's one thing we're working towards. A lot of this research, and the research that Dr. Moreno De Luca will talk about as well, is embedded in a larger research effort here at Brown called the Rhode Island Consortium for Autism Research and Treatment, RICART. And so RICART is a statewide partnership that is enrolling individuals into what's called a patient registry study. And that allows us, it's a piece of infrastructure that allows research on autism and developmental disabilities to grow and happen more rapidly. It allows us to match up individuals with ASD with future protocols, hopefully treatment protocols in the future. We've enrolled over 1,200 individuals with ASD across the age range in the last 3 years. We have partnered, even though this is really based at Brown and Bradley Hospital and Women and Infants Hospital, we've partnered with state agencies, other universities, community partners in novel ways. So we have basic scientists and clinical scientists and clinicians involved in this as well. And we have families involved in our leadership as well. So we have families of individuals with autism who are part of the leadership of this effort. This map on the right shows you just the distribution of our enrollment in Rhode Island. Our enrollment ranges from age 2 to 65 years. And this really highlights the importance of local funding of getting something like this off the ground. We have generous support from a foundation called the Simons Foundation, which is based out of New York. But this wouldn't have gotten started without really important support from the Brain Sciences Institute here at Brown, the Norman Prince Neuroscience Institute, the Department of Psychiatry and other departments here, and now the Hassenfeld Institute is helping to support some of the work involved in this study as well. So I'm going to turn this over now to Dr. Moreno De Luca, and all yours.
Thank you. Good morning, everyone. So we just heard from Dr. Sheinkopf about all the cool work that's happening in regards to identifying kids with autism early on based on how they look from a clinical standpoint. And that's a perfect segue into looking at something that happens even before then, which is genetics. So everyone pretty much has their own genetic makeup since birth. And we know that for autism, there's a strong genetic contribution. And this is marked by a very high heritability that can be between 40 and 80%. This is a tricky word because in research, people use heritability to mean something completely different from heritable. It doesn't mean that it's passed on, but it's just a measure of concordance between identical twins versus concordance in non-identical twins. So it's just to get a grasp on how genetic a given condition is. And we know that autism is has a very high genetic component. Now we know because of this, and because of recent advances in the field, that for several years, genetic testing is considered the first-year testing for all people with autism spectrum disorders, regardless of the presentation of any other clinical feature. So every kid with autism should be having genetic testing. And we're on the way to make that a reality, because right now not every kid is getting tested. And the advantage of doing genetic testing is that a genetic cause or a very strong genetic risk factor can be identified in anywhere from 10 to 40% of the cases. And if you think about that, it's pretty relevant. Almost 1 out of 2 kids with autism will end up having one identifiable high-risk, high-impact genetic cause for their clinical presentation. Conversely, there's many people with known genetic disorders who have a higher incidence of autism spectrum disorders as part of their clinical manifestation. So I have listed here some well-known genetic disorders like tuberous sclerosis, Angelman syndrome, and Prader-Willi syndrome, and the George syndrome. You may have heard about these on your biology classes or medical school if you went. But these are very well-known medical and genetic syndromes. And although the genetic causes of autism are collectively common, so we know they can account for up to 40% of the cases, each of them is individually rare, explaining a maximum of 1 to 2% of the cases. And what this means is that there's going to be a lot of different genetic causes for autism, and the chances of finding a large group of people with the same genetic cause is not that high, but of course it can be done, and I will show you some of the work that we're doing in that sense. Now this is just another way of showing you what we just spoke about. So if we consider everything that falls under the autism umbrella as affected by autism, then we know that several of these bars, which are the different genetic syndromes, may fall inside the autism umbrella or outside. And that means that not everyone with each of these genetic disorders is going to have autism, and that everything that falls under the umbrella, which we're calling autism, is not the same from a genetic standpoint. So there's a lot of heterogeneity in the clinical presentations and in the genetic makeup. Now, let's go back to what we see on the genetic testing and a quick refresher about genetics. We are looking for things that are rare. By definition, present in less than 1% of the population. So we know that every one of us in this room is highly similar in regards to our genetic markup, except for very specific changes that make us different one from another. Now, sometimes those changes contribute to things like your hair color or different clinical characteristics that don't lead to disease or to any conditions. And sometimes they can lead to trouble and neurodevelopmental problems. And this is the work that we're trying to do to figure out which of those genetic changes are leading to trouble. These changes can be in two forms. One of them is copy number variants, or CNVs. And I like the analogy of thinking of these as paragraphs. So you could insert one extra paragraph in the genetic makeup of someone, or you could remove one paragraph, and all of a sudden the text just doesn't make as much sense. So if you remove the paragraph, this is called a deletion, and if you have an extra one, it's called a duplication. And these changes in the amount of genetic material are going to have different effects on the clinical outcome of people depending on exactly where they happen on the genome. Some of them are recurrent, meaning that they happen over and over again in the exact same spot of the genome. And some of them are non-recurrent, meaning that they just happen randomly across the genome. Now, another type of genetic variation that we study are called single nucleotide variants. And this would be the letter as opposed to the paragraph, so changing just one letter. Sometimes if you replace a Y for an I, the word may still make sense and you might still be able to understand what's going on. But we're more interested in the ones that change the meaning of the word completely and give rise to problems from a genetic standpoint. So these are changes in a single base pair within the sequence of a given gene. Now, these genetic abnormalities can happen in different ways. One, they can be inherited from a parent who may or may not be affected to different degrees. And the other one is that they can arise de novo, meaning that we see them for the very first time in the person that we're testing and they're not present in either of their parents. And we are focusing for these studies in variants of high risk, meaning that they have a large effect on the clinical picture, and people who have them are very likely affected with a neurodevelopmental disorder. Now, a way that I like to conceptualize our work in the side of rare genetics is kind of using the all for one and one for all catchphrase. So all for one would mean that there are many genetic causes for the same disorder, meaning many genetic causes for autism in this case, like we saw. I'm going to talk a little bit about CMVs, so missing paragraphs or extra paragraphs in autism. And then one for all is kind of flipping the question and thinking about it from a different starting point. So let's start with the genetics and see what the whole clinical spectrum and the clinical manifestations are. So many disorders due to the same genetic cause. And many of these disorders could be psychiatric, neurological, but also involve several other organ systems like the kidneys or the heart. And we'll see what we're doing to address those two questions. So going back to the all-for-one strategies, since these genetic variants are so rare, that means that we need very large cohorts to really understand whether or not something is causing trouble or is associated with disease or with any specific conditions, or whether it's just a variant in the population that doesn't lead to any problems clinically. To do this, there are several strategies that people have taken. One of them is looking at ASD registries, for example, like the Ricard cohort, where we have a very detailed phenotypic characterization of the patients. They tend to be small, so the Ricard cohort is actually pretty large compared to many of the other registries of patients with autism. So trying to establish whether something is pathogenic, which is the name we use to say that something is giving rise to problems clinically, is very hard because the numbers are small and it's tough to compare cases versus controls. Now, the alternative to that is to use clinical registries, which may have limited clinical data, but they are extremely large. So this would be, for example, people referred for genetic testing to a laboratory, and they can rise up in numbers very quickly to the tens of thousands or even hundreds of thousands. There are several projects of this magnitude in different countries, some of the Scandinavian countries, and even here in the US, like in the Geisinger Health System cohort, who has about 100,000 people who they are looking closely at. So what we did a little while ago was to try to use the power of the clinical registries and establish pathogenicity or causality of some of these variants, and then bring that information back to the ASD cohorts to try to tease out who has one of those variants that we deem pathogenic, using a two-tiered approach. And with this, we were able to find that de novo and familial copy number variants are highly relevant, and only half of the clinically relevant CNVs in ASD were known to be de novo. So there's been a lot of fuss around de novo variants and a lot of emphasis on things that happen for the very first time in the affected kids, but we have shown that things that are running in the family and are rare can also contribute to this condition. We found associations between autism and deletions and duplications, which is another word for CNV, so the paragraphs missing or extra paragraphs, in these genomic coordinates. Some of these are associated with well-known disorders like the ones I mentioned before, and some of them are rather new. And using this two-tier strategy allowed us to increase in 26% the diagnostic yield for recurrent CNVs in autism. So it allowed us to draw much stronger conclusions that we wouldn't have been able to see had we restricted our analysis to autism-only cohorts. Now let's go back to the other strategy. So one for all, meaning many disorders due to the same genetic cause. And we started this project looking at a very specific genetic abnormality called the 17q12 deletion, which is a copy number variant that happens in chromosome 17. I was working on a clinical genetics referral center at that time, and I started seeing that some of the kids that were referred to us for testing because of autism had this deletion that had not been identified before as associated with any neuropsychiatric phenotypes or clinical presentations. So this deletion is about 1.4 megabases in size and has 15 genes. It's not too large in terms of cytogenetics and genetic sizes. It's fair, but it's not too large, and you would not be able to see it with a microscope, which you can do for the larger deletions. It is recurrent, meaning that every person that has a deletion at this genomic address is going to have the same 15 genes involved. So that makes comparing patients easier and comparing cases and controls easier as well. And this deletion was originally associated with renal disease and diabetes, but with no apparent neurodevelopmental issues, as we discussed a little earlier. This is just a blow-up of the type of data that we work with. So we see on the top, that's a chromosome. The little orange box is the specific part of that chromosome where this deletion is happening. And then below, we have a blow-up image of the area that was involved in the deletion. And what we see between the two blue bars are the 15 genes that are involved in that deletion. And then below, we see that all those dots are the ones that are showing us by deviating from the normal baseline and going below, we can see that there's a deletion there. That's how we can tell. Now, we recruited 9 of these patients for a detailed study, and it turns out that 6 out of the 9 had autism, and they also had a whole host of other neuropsychiatric comorbidities, including deficits in coordination, cognitive impairments, language impairments, anxiety, but also gastrointestinal problems or visual acuity problems and hypothermia. Importantly, they also had several of the features that had been described associated with this deletion, so urinary tract malformations, reproductive system malformations, and diabetes mellitus. And after looking at this small group, we wanted to pose the question in a much larger scale and contact all of our collaborators to see if this was indeed contributing to autism in different larger cohorts. Just to show you first, these are the patients who gracefully agreed to participate in our studies. And each of the columns is one patient over time. And we can see that at very early ages, they look a lot alike. They have some mild common features like a broad forehead and a depressed nasal bridge, but you wouldn't be able to pick them out on a clinic. And then you can see the progression of the facial features as patients age. Now, as I was telling you, we sent out a larger call to see how frequent this was in very large samples. And we looked at 2 autism collections and 2 schizophrenia collections. And it turns out, this busy slide is just to tell you that it was very common, well, for a rare variant, in cases, and we didn't see it in any of the controls. So We found this deletion in 24 out of 23,000 cases that we looked at with both autism and schizophrenia, and in 0 out of the 52,000 controls that we looked at, with a very significant evidence or p-value. Now, the conclusions from this one-for-all strategy is that this deletion indeed does pose a high risk for autism and also for schizophrenia, so both conditions. It's rarely seen in controls. The majority of cases where we see this are de novo, meaning that we see them for the first time in the patients. And then when it is inherited, the parent who had that variant was affected with bipolar disorder or other neuropsychiatric conditions. This deletion is associated with several diagnoses, as we mentioned, and we know that one or more of those 15 genes on that interval is going to be the one responsible for the phenotype. So it gives us a way into the biology to start functional studies and try to tease out which of those genes is the responsible one, hoping to find commonalities with other genetic causes of autism. And we know that these results add to the evidence for shared genetic pathways in neurodevelopmental disorders like autism and schizophrenia. Now, this is one of the parts of the work that I find the most rewarding. Doing this study gave us a chance to meet a lot of these families and get them together, and we organized the first and second family meeting for people with 17q12 deletions. And this is a picture. We had a very nice shirt for every one of them. And it's a great chance to tell them about what we're finding, to try to close the loop, because many times people participate in research, but they don't hear the results directly from the researchers, and we wanted to make sure that they were in contact and direct communication with the research side of things, but also to allow them to be in contact with expert clinicians and researchers so that they could ask specific questions. So we had a roundtable with endocrinologists, psychiatrists, geneticists, and cardiologists that patients and families could go around and ask specific questions. And we also gave them a chance to meet each other and form a very strong support network. So this is one of the advantages of starting with the genetics. It kind of highlights what the risk factors are, but also what the strengths of many of these kids and people are. And it allows us to better understand the trajectory of the life of people with these genetic variants, to tailor our clinical management to that trajectory. Now, the next steps, kind of building upon what we just discussed, would be to continue understanding the genetic contribution of ASD for families in Rhode Island, specifically through the Hassenfeld Institute and the Reichert initiatives that we learned about recently, and then moving this one step further and using genetic data to identify opportunities to guide treatment under the umbrella of precision medicine. And I'll be happy to talk a little bit more about that in the question time if you guys have any questions. And the idea is that this would also extend beyond research. So hopefully this will be all part of a larger neuropsychiatric genetics division that would encompass clinical care, education, policy and advocacy, and entrepreneurship as well. So with that, we'd like to thank everyone for being here and all our collaborators, and we'll be happy to take any questions.
Thank you. We are going to sit in front. We wanted to leave plenty of time for questions. Our goal in the talk was to give you kind of a sense of some of the cutting-edge work that's being done around autism here at Brown. But I'm sure our experts would be happy to answer any questions that you have, and we'll just sit at the table. The only thing we ask is if you can come up to the microphone, because they are recording and they want to make sure we can pick up your questions. But feel free to ask any questions of any of the panel members.
So I'm Dr. Lula, and my daughter's a freshman in the class of 2020. I happen to be a pediatric psychiatrist and love the field. It's cutting edge, the 17q12 deletion, and clearly all of us are looking at that too. But have you guys taken it one step further with the clinical management? Will it differ? And where are the neuropsychiatrists looking at that end?
Absolutely. So thank you very much for that question. That's exactly the type of work that I am doing right now, that I look forward to build kind of my career, continue building my career on. And what's happening right now is that there are many questions from psychiatrists and neurologists in the sense that we're doing this testing, but then what? We get the results back, and then what happens? How does that alter clinical management? And my argument is that there's a lot of stuff that we could be doing right now that are just being missed opportunities. So for example, going back to the case with the 17q12 deletion, I actually saw a patient back before coming to Brown when I was at Yale, who had one of these deletions and was hospitalized because of bipolar disorder. She was placed on 2 medications, one mood stabilizer and one antipsychotic medication, and they were lithium and olanzapine, which is pretty standard treatment for both conditions. But it turns out that knowing that she had this deletion meant that we were keenly aware about the medical comorbidities that she was at risk for, and we know that lithium is highly associated with with renal problems, and part of the phenotype associated with the deletion is early onset renal failure and renal cysts. And again, olanzapine can be associated with weight gain, and this deletion is associated already with increased risk for diabetes. So just using that to pick a different set of medications is very helpful, and it's something that's grounded in the clinic and that we can be doing right now. And this is one of, I'm going to say, tens to even 100 examples like this, where the clinical implications are going to vary depending on the exact thing that we identify. But we're trying to compile all of these together as a field to put forward guidelines on how to use this information and to identify decision points where genetics could clearly alter clinical management.
Thank you.
You're welcome.
I'm a developmental pediatrician, and many times we make the diagnosis of autism when we order standard labs.
Mm-hmm.
So in addition to chromosomes, and we do a FISH analysis, and we do a microarray testing, that's
Mm-hmm.
the panel recommended, right?
Perfect.
And what specifically would pick up? Will it be the microarray? Would it be the FISH specifically for 17q?
Mm-hmm. So that's a great question. And there are a lot of different genetic tests that, like you pointed out, that we could do. Right now, the current recommendation is that every kid with, or every person with autism should have chromosomal microarray testing and Fragile X testing.
Right.
The other tests you could add on if your suspicion is high for any specific disorder. Chromosomal microarray testing is a genome-wide test, so you would be able to pick up this 17q12 deletion, but also a whole host of many other of those heterogeneous genetic conditions. And Fragile X testing is so frequent that for a rare disorder, so it's about 1% of the autism cases, that we still need to test for that specifically, also because it would not be picked up by chromosomal microarray testing.
Right.
So my recommendation, which is pretty much the same one that the American Academy of Pediatrics and the American Society of Human Genetics has, is to do chromosomal microarray testing first, along with Fragile X testing. And then, if those results are negative, it could open up testing like whole genome or whole exome sequencing. If you have any specific questions, you could be doing FISH or karyotyping if you have a very targeted question. But basically, chromosomal microarray testing has kind of replaced some of those tests as the initial standard of care.
And there are some companies out there that are actually doing buccal swabs. Do you have any feedback on that for the microarray testing instead of blood work?
Yes, I think the buccal swabs are getting better and better. Still, the results coming from blood work are better, definitely.
Obviously.
But if that, we know how difficult it is sometimes to get a blood sample in a person with autism. So buccal swabs are a feasible option as well. If you could get the blood testing, that'd be better. But different companies are standardizing those results and are able to do buccal swab testing as well.
That brings up one issue for the Reichardt study that we are running. So 1,200 people enrolled so far. We do get biological samples for all those individuals and family members. And Daniel mentioned that it can be difficult to get samples from some individuals, and especially because our participants range not only in age but in functional level. They're not always going to understand what's being asked of them. So the kids who are more impaired in terms of their language and comprehension, it can be really quite challenging to get these blood samples. And the cheek swabs, the buccal cells, can be a good alternative. And it just, from my point of view, highlights some of the wonderful features of collaboration here at Brown, because we have at Bradley Hospital clinicians and support staff who sort of have this experience with individuals with ASD and developmental disabilities who have very severe presentations. And so there's the expertise that allows this huge range of participation in research that's, I think, rather unique. And so that, there's the clinical end, but there's also the research end there that was your question made me think about.
Any other questions about the research specifically or generally about autism where we could be helpful in our remaining time?
What you're doing is fascinating, and I'm curious if Brown is doing anything as it relates to individuals on the autism spectrum that are, say, in high school, for example, and parents are trying to figure out a path for them from a career perspective, from an education perspective, or if there's other groups you're aware of that do much in this area that would be helpful.
So we, I may have mentioned that we have a strong collaboration with parent organizations as part of Reichardt. And one of them here is an organization called Autism Project. It's a Rhode Island-based organization, but it's really rather unique in the sense that they are sort of this amalgamation of families and professionals working together. And a lot of those issues that you describe are really now coming up for the families in that organization, where the kids are in high school, in later adolescence, moving into early adulthood at a time when transition between systems of care is really a prominent and troubling and very difficult issue. So high schools are sort of a known entity. But this transition from pediatric to adult care from a state funding point of view, in some cases it's a money issue in terms of the programs that are available for people. It's a big issue. It's something that is being worked on here. I don't have a sense actually of what's working best right now there. But it's certainly something that is around the table that when we talk, sort of a topic of weekly discussion. It's something I think that I know the Autism Project, for example, in collaboration with us recently, received a grant from the federal government from HRSA. I forget what HRSA stands for.
Health Resources Service Administration.
Thank you. And that may impact some of those issues, because some of what they're trying to do is to help patients and families navigate these systems properly so they can connect with the resources that are available to them. But it's not just sort of a connection issue. I think there need to be actually new programs that do not exist yet that support individuals. And one issue that I think is really prominently sort of challenging for people with autism is you can have a group of individuals with high developmental need. They may be minimally verbal, have intellectual disability, and they're going to be clearly eligible for state, federal funding for long periods of time in their life. But then there are other individuals who are not as impaired from the point of view of standard criteria that the state or federal government uses, and they can fall through the systems of care, the cracks, very easily. So I think there need to be sort of new model systems that help individuals who might be, for example, quite bright, who may be even college-bound, but need supports from a social point of view on job sites in the community to be successful. And I don't think we're there yet.
Thank you.
I just want to comment. There is I think one of the challenging things on autism spectrum, as Dr. Sheinkopf is saying, is it is a broad spectrum. There is one program that I'm aware of in Rhode Island, at Rhode Island College, where folks who have been able to get admitted to the college who are on the spectrum are able to apply to this program, where they get a buddy and they get some structured parts of being able to participate. It's a small program, I think 5 or 10 that they're taking, but I think that there are a lot of these small programs where they're trying innovative things, and my hope is from the Institute we'll be able to, as our first year, but really try to connect with more organizations to know about that. But if you have specific questions, I'd be happy to chat with you afterwards.
And just to follow up on that from a research standpoint, we're also trying to understand better, at least for the genetic side of things, the neurobehavioral profile associated with several of these genetic conditions, with the aim of identifying areas of strength as well. So many of the focus of research has been areas of weakness, but we also want to see what are the areas of strength so that we could tailor specific programs. Let's say if there's a very significant verbal impairment, but many other abstract reasoning abilities are very high, then to try to get a grasp from a research standpoint first, but eventually to move that towards public health interventions and capitalize on those strengths.
Okay, as a non-scientific layperson, I'm trying to understand what de novo means. Does that mean, is it after birth or in the womb, or and what, if that is the case, what causes that to happen? And has there been any research on not doing whatever it is that causes that to happen? And the other final question is, if that's what it is, does that new gene splicing CRISPR technology hold any kind of promise for having some impact on this condition?
So that's a very good question. De novo means basically that you don't see it in the parents, and there are several points during development where that can arise. Most commonly is during either recombination of the parental gametes. So once we know that the eggs and the spermatozoids recombine their DNA, and that's why people are not identical to their brother or sister. And sometimes that recombination process can go wrong, and that's where de novo issues arise. It's also very important to point out that everyone in this room has one de novo change in their genome. So it's very common, it happens to everyone, and is the thing that causes trouble is knowing exactly where that happens. So all of us have some of that, so it's not like you could say everything that's de novo is going to be pathogenic and we're going to have to worry about. So we're trying to understand better which are the ones that we need to worry about versus the ones that aren't. It can also happen even after recombination. So if after the gametes have fused and when the embryo is developing, if it happens at that point, it gives rise to something called mosaicism, which just means that some of the cells in your body would have this genetic abnormality and some others won't. And that also impacts how, like, the clinical presentation of the patients. And in regards to things that increase risk, we know that there's a few things that increase risk for that. One of the major ones is advanced paternal age. So the older fathers have a higher chance of having de novo mutations in their gametes that will end up in their kids. Now, in regards to the CRISPR technology, as you may have heard, that has revolutionized tremendously biology, and it's just for the people who haven't heard about it, it's like a very precise set of scissors that you can use to cut and replace DNA at any point where you want to do that with extreme precision and without having effects from insertions of extra genetic material that you don't want to be there. And they have used that to correct mutations and deletions or insertions in animal models. So I think the field holds promise in that sense now. We would have to wait and see where things land, but that's a very interesting technique.
Thank you.
So I think we're at the end of our time. Happy to have you come up individually if you have other questions. Thank you for participating today.